Hi, everyone. Welcome to Conscious Living. We're live here on Facebook and recording in the studio at Specially Produce Network. And I'm here today with Andrea Meyer, midwife of Ocean Midwives at Ocean Wellness. Welcome, Andrea.
Thank you. Thanks for having me.
I'm so glad you're here.
I'm excited and anxious and nervous to be here, but happy to share what I know.
Oh, I'm so excited. I mean, what you know is just a vast array of really sharing. I don't know how many times people will share over a podcast or over a learning opportunity like this to learn about what midwives do and an alternative to birthing practices that are available here in America and other
Hmm.
countries. And I think it's fascinating. I am a ex-NICU nurse. I still work with a lot of neonatal babies in the hospital. And I've been indoctrinated in a certain way of delivering babies and been back for five or 600 high-risk deliveries in my career. And, I really grew up never really understanding that there are other ways to work with this natural, not a sick process, but a
Hmm.
natural
Hmm.
process of delivering babies.
Hmm.
And I'm just so glad you're here with us today to explain what some of those natural processes can be like outside of the hospital setting and what can be positive and supportive in those ways without looking at it from maybe a fear state or a danger state or all of those kinds of processes. Like, how many
Thank
babies
you.
have you participated in delivering over your career?
Probably somewhere right between 800 and 1,000.
Yeah, that's just amazing. So you have a rich
Yes.
history
Yes.
of sharing about how wonderful this experience can be.
Yes, yes. And I have three kids of my own, all born at home. So I
Wow.
have that really wonderful experience behind me as well.
Your own personal
My own
experience.
personal experience.
Yeah. Wow.
I want to touch on something you said first,
Yes.
is about fear.
Yeah.
And I think that I do believe birth is natural. We've done it forever.
Yeah.
But I think fear is also a natural part of who we are. And when we just address that we have fear, and it's normal to have fear in childbirth or parenting or everyday life, it's an opportunity to say, what's going on and what do I need to do next? We
Yes.
don't need to continue in fear. We don't need to make decisions because of fear. We can
Exactly.
decide which way we want to do something. Um, and I think that's probably how people get from the standard hospital birth that's currently happening in our country to out of hospital birth in a birth center or a home or wherever they're going to have their baby.
Yeah.
I just want to say, midwifery is probably the oldest profession ever.
Isn't that amazing?
I think that before men were paying for something, as the joke goes,
Yeah.
women were supporting each other having babies and trying to figure out what we can do to help keep women and babies safe and help keep women and babies having a positive experience.
Yes.
And that leads to a positive newborn experience and postpartum, and then healthy continued uh, reproductive life.
Oh, I agree with you. I mean, I even recently saw a show or a documentary about us humans. We're the only species on the planet, it seems like, or has been noted, that when we go to deliver our offspring, we need help. There are many
Hmm.
other animals and that can deliver on their own without needing any help, but we are the only, as the apex, if you could call it predator on the
Hmm.
planet,
Hmm.
we actually need each other to deliver our babies.
Well, I think there's a school of thought out there. Some people would call it free birthers, is a term for it, where they would say that we don't actually need help to deliver our babies.
There you go.
But same as any animal, if we ran into a glitch or a problem or simply fear or needing more support or comfort, then that's when we need to have an attendant with us. That's when we need to have somebody there, whether it's your partner or your child or a doctor, nurse, or a midwife,
Right,
doula, a
right.
support person, or an expert in something that's going on.
Yeah.
Because most often in my work, I'm just there witnessing this amazing family event, um, and just offering ideas or a touch, a hand, a thought. Um, and really not doing much other than being sure to clean up before I go home to make it easy for the family.
Yeah.
I think when you talk about fear, there's that peace of mind that there's somebody there who has more experience
Mm-hmm.
and more tools. And so maybe, would you like me to touch on what
Please.
types of things we bring to a birth or we have
Absolutely.
stocked at a birth center birth?
Absolutely.
I do have the privilege right now. I've been working a home birth practice for my entire career, but in the last year, I had the opportunity to join at Babies in Bloom, which is a birth center up in North County. And so they keep everything stocked there. We keep everything in our cars, so to speak, or
Okay.
at hand. And in terms of what you might be familiar with from your setting,
Yeah.
we usually bring oxygen and a bag and mask to resuscitate baby. We have meds for hemorrhages and IVs for fluids or antibiotics. Um, we suture, so we carry lidocaine and suture gear and instruments and birth instruments and cord banders for the belly button and for the umbilical cord tying off. I have a birth stool. I have lots of interesting things, like a set of combs for pain relief for mom to hold in her hand, or a birth ball to lean over or bounce on. Some things you wouldn't have
In a
in your
hospital setting. Yeah.
well, you wouldn't have in the NICU,
Right.
but really nicely, CNMs who've been really working diligently in the hospitals to bring lots of comfort and different alternative to hospital procedures have brought things such as birth balls and peanut balls and um, I don't know what you call them, rings and things you can hang on
Yeah.
to help women get in different positions so that they're really comfortable as possible, or as effective as possible in getting their babies out.
Right.
So, what else do we have that? I also carry a homeopathic kit
Okay.
and an herbal kit because sometimes those are needed as really urgent medicines that we can use, as well as some Chinese herbs to stop bleeding or to help somebody clear their lungs or to relieve fear or to progress the cervix. So midwives carry a lot of different tools, and they always have.
Wow.
They always have. They've always used whatever was around.
Yeah.
Whether it's boiling water and tearing rags, I still don't really understand what that was used for.
Okay. That was my first thought.
I have boiled water, which probably leads me to one of the most common questions couples ask, which is about water birth. And you were asking
Yes.
about that as well.
Yes. Yes.
So we have been known to boil water on the stove to warm a tub back up.
Okay.
So perhaps that's what they did back then. But people often ask about the logistics of a water birth.
Uh-huh.
And there is a hospital out in Poway, Pomerado, which actually has birth tubs in the room,
Wow.
which is really nice and easy to use. And the birth centers often, I think in San Diego, they all have birth tubs in the room.
Okay.
So those are fixed tubs. But when we go to somebody's house, although there are lots of great spa tubs in the new developments, mostly people purchase or borrow or rent a portable or an inflatable tub.
Wow.
So I think we can probably all remember when we have gotten in a little inflatable tub as a kid
Uh-huh.
and went swimming in our backyard.
Yeah.
Well, it used to be that they would sell those only in the summer season.
Right.
And another midwife and I, Paula Tipton Healy, discovered we could order them from overseas in 500 count and put them in her shed. And so we bought this huge amount of tubs.
Wow.
And about that time, some researchers and some groups around the world were very interested in birthing their babies into water.
Yes.
And so the tubs became really popular. And so you would buy one from us or from the store. Now you can buy them online, and you can find many videos online about water birth. But you inflate this kid's tub, or now they have actual birth inflatable tubs.
Yeah.
And you put a liner in it that's fresh and clean just for you. And then we recommend you get a potable water hose because it does not have lead inside the hose.
Yeah.
And you just hook it up to your shower head or a faucet, and you fill your tub from there with hot water and water from your water heater, and there's your tub.
Wow.
We suggest
So you don't have to do anything special to the water.
no.
You don't have to have distilled water.
No, you don't have to have distilled water. We suggest you put a thin tarp underneath and some beach towels around it to catch the drips, because mom will often get in and out of the tub.
Uh-huh.
We
And
can
the partner can get in the tub too
The
with them?
partner and the kids can get in and out of the tub. It
Wow.
really depends on what the mom wants.
Yeah.
Because really, we always say as a midwife that we follow the mom. It's the mom's job. She's doing this. It's her baby. It's
Right.
her body. We want to follow what she needs.
Yeah.
I have had clients that put salt in the water.
Okay.
Salt. We're made of salt water.
Right.
There's the amniotic fluid is salt water.
Yes.
So they'll put salt in the water to try to make a saline water.
Uh-huh.
Um, And I've had some clients put in hydrogen peroxide. I'm not sure why. I don't think I would recommend it.
Yeah.
But otherwise, just straight from
Straight
the
up
tub.
water.
Hmm.
Okay. And they go through the birthing process, and the baby crowns.
Well, so before you get there, you go through labor.
Yeah.
And what we recommend as midwives, you're giggling, or is she making funny
Well, no,
birthing faces behind
I just
me
have
in the
very
booth?
little history of L&D. So
Right,
I was
right.
going right to the delivery.
And because right after the delivery is your
Right.
your patient,
right.
as we would call it, our client.
Right. Exactly.
We don't call them patients,
Right.
but when they do see you, they are
Right.
definitely patients.
Right.
But first we have labor. That's probably the most common time a woman gets in the water
Okay.
is simply for the comfort that the water brings to her
see.
while she's laboring.
So it helps them feel less gravity.
Less gravity. You can imagine every time you get in your own shower or every time you get in the bathtub, you walk in and you go,
Right.
and you've relaxed.
Right.
And doing that relaxing is what really helps the labor to progress.
Yeah.
And I can talk about it again later.
And decreases pain as well.
Yes. And also, I think increases the hormones that we're looking for to bathe the baby in.
Okay. Right.
So we can talk about that more later. But,
Yeah.
So women get in and out of the tub. Some studies even recommend you get out every 2 hours, have a little walk, go pee, and come back. And that will bring that feeling back again because labor is about moving in stages.
Mm-hmm.
And as the labor picks up and gets stronger, then the endorphins come in and get stronger to support it.
I see.
And so the tub helps to do that. If you get in and out, it helps you to
I see.
climb that ladder together.
Well, and that's great to know too, because I think many people do envision, okay, we fill up the tub, we get in, we get deliver the baby, and all is good, and then the baby, 5 minutes later is, all ready and in a blanket and ready to go. Right?
Kind of like as if when we used to give babies bathtubs all the time.
Right.
But we're learning to not do that so much to protect their biome, and
Yes.
even many of the hospitals are delaying the bath for the first 24 hours, which
Right.
is excellent, good health practice.
Right.
But then, yes, so many women or families, dads, parents, believe that birthing the baby then into the water is more than about the mom being comfortable and relieving her pain.
Yeah.
It's really also about what's the baby's experience.
Yeah.
And many people believe that the baby coming out like it would be in a hospital room into this booth, there's lots of bright lights and the temperature significantly changes. And
Right.
then people are touching the baby and the baby's never been touched before.
Right.
It's all very new. That adults can imagine that would be a shocking feeling to a
Yes.
baby.
Yeah.
I imagine it would often be shocking as well.
Yeah.
Dr. Laboye, a French obstetrician, thought so too. And he suggested that after everything was a little bit stable, that then we bring in one of those little NICU beds.
Yeah.
And he would fill it with warm water. And then they would just let the baby sort of soak, being held up, their head out of the water, and just soak in the water.
Right.
And what he noticed with the lights dimmed and the baby in the warm water is that the baby would tense up at first and then start to relax and settle, and the arms would open and the legs would relax.
Right.
And then he noticed also that the hands and feet would turn pink, which, as you know,
We get acrocyanosis.
yes, it's not a very common thing to see a newborn baby with pink flushed color in their hands and warm hands and feet.
Right. Because they went into the diving reflex. And they went into their autonomic nervous system, which shunted blood just to their central and brain area. And
I imagine it was a tight squeeze coming out and that it's supposed to do that.
Right.
But these were just things he noted.
I think it's phenomenal because you can also envision too that when a mom is somewhat pelvically suspended in water and they're going through the birthing process, then we're not having the pressure of the bed or where they're laying on a flat surface where the pelvis then gets distorted. And when the pelvis is distorted, it's harder for the baby, especially full-term babies or babies with larger head circumferences, to come through that vaginal area. Mm-hmm. And they also get distorted physically through their cranial plates, their shoulders, or their hips,
Hmm.
and then have more difficulty times physiologically transitioning from intrauterine life to extrauterine
Hmm.
life.
Hmm.
Yeah.
Hmm. I think when I talk to parents, I really feel as though I'm an advocate for the baby.
Yeah.
And I think that when I talk to parents, I try to caution them to be careful to not assume what the baby's experiencing.
Yeah.
So I think that's very possible. I've never quite thought of it like that, kind of almost being suspended in space in the pelvis.
Right.
And of course, my mind, being a midwife, goes to, well, what about somebody who actually needs pressure?
Yeah.
Who needs to be sidelying to turn their pelvis a different way to make it wider for the baby to come through? Or
Yeah.
what about the baby that won't put its hand down
Yeah.
and needs to come through?
Yeah.
And mom needs some different pressure in order to open that diameter. So
Right.
it's really quite a unique experience to each baby and to each pelvis and to each mom
Yeah.
what that baby needs. So that's why we say set the tub up,
Yeah.
try it, see what's working.
Yeah.
And very commonly you'll notice first time moms want to actually get out of the tub and push out with gravity because they actually can feel their progress or feel that success and pushing. They can feel their push.
Okay.
You can imagine if you're in the tub and you're pushing,
Right.
it takes away some of the sensation,
Yeah.
which is great for labor, but not so great for pushing if you need all of your wits about you to do it the first time.
Yeah.
Whereas you have a mom who's already had vaginal births, those
Yeah.
babies usually come out much more easily.
Right.
They just really flow out much, much. Oh my gosh, it's the babies we all miss are the second time moms. And those moms get in the tub, and when the sensation's taken away, they actually really feel even more than outside that baby moving through their body,
Uh-huh.
where that baby is in their body. They have a great sense of that
Yeah.
and feel like they're very much participating in this descent
Wow.
of the baby, and the baby comes out. It's really, it's quite remarkable. It's
Oh,
quite
that
remarkable.
sounds awesome.
I think some midwives, just the same as some parents, find water birth a little scary
Yeah.
because it is unknown what exactly the baby is doing inside.
Yeah.
As midwives, we carry Dopplers. Oh, I didn't mention that.
Right.
Dopplers and fetoscopes and Pinards, which are all tools to listen to the baby's heartbeat.
Right.
But even with the best baby's heartbeat, right at the end, you get a great heartbeat and then the baby comes out. That still doesn't completely tell you where the baby's going to be at when it arrives.
Right.
So if a baby does need more oxygen than it was getting inside,
Yeah.
the worry is that as soon as the head is out or the chest is out in the water, it'll breathe in and breathe the water in.
Yeah.
I
Do
imagine
you see that though?
not super often, and the statistics have not shown that to be the
Yeah,
case.
because they have that reflex not to breathe in the water at that
Mhm.
point.
I think there must still be, I don't know all the scientific evidence or why or what
Yeah.
they're studying, but I think it must have something to do with the fact that it's not air, it's often warm, and there's a sense of pressure around you.
Yeah.
Although it's different, it's way more pressure of the water on you at
Yeah.
the bottom of the tub than it is the air on you
Right.
when you're out of water.
Right.
And
Right.
so what we see is that the babies don't take that first breath. And then moms just
At the
reach
perineum.
at the, yeah.
Yeah.
Either when the head is out or
Okay.
even when the babies come out and they're being brought up or just floating up to be
Right.
picked
Because
up.
they're still getting blood flow through the cord and the placenta.
Absolutely.
Yeah.
Which is, I think that, I think I'll take some kudos for midwives here. Midwives have always wanted to leave the cord intact
Yeah.
and flowing or doing whatever it needs to do until the placenta is birthed.
Yeah.
And now they've done some studies with premature babies in particular,
Yeah.
where the new plan now in the NICUs, you probably know this
Not yet.
more than me.
No, I've
Oh.
been a little bit out of the NICU directly.
Good for you. But I think really here, even here in San Diego, the plan is they try to keep the cord intact, especially for babies that are compromised or preemies or anything like that, to keep that blood flowing, just like you're saying.
I think so too. I mean, the placenta was designed to give a large bolus of blood to the baby, knowing that the baby would not fully eat a full meal that day or the next day, and that the milk wouldn't come in for 24, 40, 48 hours or so. And so the baby gets a large bolus of blood, which is also fluid and nutrients, and the baby lives off of that for the next couple of days. And that when it's cut too short or too abruptly, then the baby doesn't get it. Now, of course, when the placenta abrupts or other birthing issues happen, yeah, then you can.
And that's pretty
It's a
rare.
and it's a whole
Yeah.
different process
Yes.
of how you would resuscitate the baby and support the mom. But I actually have, and I was interested in talking with you about this, where I've seen in other countries where they've actually birthed the placenta,
Hmm.
and they kept the placenta. One couple kept the placenta
Hmm.
in a dim sum,
Hmm.
wrapped in a cheesecloth,
Hmm.
and a big steaming basket, and so it would dry out naturally.
That's
But
a great idea.
I know it was
I
really
mean, we
cool.
always just use, a Chuck's or
Yeah, I know
whatever bowl they have in their house
it
that they
was
want. But
breathable cheesecloth and then a dim sum so you could put the top
that's
on
a
it.
great idea,
And
especially in the summer.
I guess they made a little hole on the side. But then the baby let go of the placenta
Hmm.
and never had the cord
Hmm.
cut.
Hmm.
And so never felt from a spiritual aspect
Hmm.
that first separation.
Hmm.
Right? So never felt separate. And it allowed, as an individuated being,
Hmm.
it allowed itself to disconnect
Hmm.
metaphorically and literally.
Hmm.
And so it dried. And a lot of times the placenta would dry, and at the cord site it would dry,
Hmm.
and it would kind of meet in the middle.
Hmm.
And it was fascinating. And I think in our Western medicine culture, we're worried about that, like
Hmm.
infection. We're
Absolutely.
worried about auto transfusion. I've been back for one delivery, and it was a very high risk delivery with a lot of other problems going on with the mom. But the baby had lost a lot of the blood, and the blood went back into the placenta. And the baby had a very bad outcome. But it was very interesting because that was the very first time I saw that. And we actually did a lot of studies about that case. And they found that, I don't know, it was like 1 in 10 million babies. It was very rare that a baby would have the blood go back to the placenta and not fill the baby.
I've never even heard of that before.
Yeah, see?
I mean, it makes sense that it's possible logistically,
Yeah,
completely.
yeah.
But I would think then that you had a baby that really wasn't breathing or the lungs inflating
Yeah, the baby was very,
because
very compromised.
yeah, that's so integral to I just tell my clients to closing the doors, like closing the door that the blood goes back to the placenta. You
Yeah,
have to have those lungs inflating. You have to have that change of pressure inside the
right,
body.
right.
That's one of the things
That
that's
alters the
super
blood flow.
important. Yeah.
Yes,
And then that door sort of closes to the placenta. So then you just have it pulsing towards the baby
right,
and not back to the placenta.
right,
But the second thing, which was I'm sure happening, is that the baby didn't have enough oxygen already
right,
in its system, which it might have been born with. So its closed system, placenta to baby,
right.
simply didn't have enough oxygen.
Correct.
And it was probably really difficult to oxygenate that baby because you
Yes,
have to have the oxygen saturation level be high enough to keep the door closed.
right.
So,
There's a
yeah, I
lot
mean
going on
that's really
physiologically that we
different. And
underestimate.
I'm gonna knock on wood here right now that that's not something that any of us runs across
That's right.
at
But I
the
mean, it
births.
was really facilitating and fascinating and wonderful and beautiful to be able to see a baby and their placenta disattached from each other naturally. And it took about 2 weeks for
Oh, that's a long time.
I know, isn't that
It must
amazing?
that I wouldn't think it would take that long.
Yeah, but everything was fine with the baby and everything was fine with the placenta, and it fell off naturally. And
Well, people do that here. It's not a very common request.
uh-huh,
They have a name for it, at least what I learned
uh-huh.
in my work. They call it a lotus birth.
Okay, yeah.
And I thought for years that was a beautiful spiritual name for this style of the umbilical cord. But the truth is that actually somebody named, at least I heard somebody named Lotus came up with the idea and put it on the
Wow.
web. And so it just got coined Lotus birth from
Yeah,
them.
yeah,
But what we do here, what I've seen around here is that we salt it and put typically the herbs lavender and rosemary because they're very
uh-huh,
scented on it.
uh-huh.
And then you sit it somewhere where it can have some air, but not be too, heated or cold or something, whatever
Yeah,
your
I'm pretty
environment
sure this
is.
couple did
Yeah.
that too.
Yeah, the steamer is a great idea.
Yeah,
And then you just wait for it to fall off
yeah.
and it just dries. A lot of families in San Diego and in midwifery using midwives will use powdered golden seal on
Wow.
the cord.
Okay.
And that really seems to dry it up very quickly and helps it to come off more quickly than if you don't put anything on it.
Right.
I think that's the alternative we've come up with. People coming from the medical model or from a hospital birth and then out into our birth, we used to in the hospital use a lot of alcohol around the cord,
Mm-hmm.
and they've learned now that that really slows it down.
Mm-hmm.
They've also put gentian violet on it. They also put what's the silver nitrate,
Silver nitrate.
which is actually painful,
Yeah.
quite painful.
And
So they've
and
stopped
if you
that.
put that on the skin accidentally, it really does cause a lot of scarring and
It
granulation.
hurts. It's
Yeah.
owie. So midwives thought, well, parents want something. They think we need to have something
Right. To keep it sterile
to
or
keep it
clean.
sterile or clean. And yes, there are things out there. And siblings could bring dirty hands into the house. So
Yeah.
so powdered golden seal or cord care that has some other ingredients in it, it's just some herbs. You rub it on and
That's
it
fantastic.
just sort of dries it up and prevents that bacteria and
And
viruses.
then we go back to plant medicine. Right.
Definitely. Again, we carry herbs and homeopathy and whatever somebody needs.
Yeah.
When you use the cord care, we see the cord fall off often 2 to 4 days.
Okay.
When we don't use the cord care, I've seen it fall off as early as 2 days, but typically about a week. That's why I was
Okay.
thinking 2 weeks was kind of a long time.
Yeah.
Maybe they have more humidity
Yeah.
where they were than here in San Diego.
Yeah.
It
That
is
can-
dry here.
That can be, yes, it's very dry here. So that does support it. Like I bet growing up in Hawaii at 75 or 95% humidity, it'd be a little more challenging. So that's where that plant medicine might help as a desiccant to
Exactly.
to dehydrate some of that to support its natural time.
What's really happening at the belly button is that the cord is dying.
Right.
And that bacteria is eating it away and it's necrosing, and that's what causes it to fall off.
Okay.
Whether the placenta is attached or the cord stump is attached, it's the same process.
Yeah.
So I've heard people say, clients of mine say, they could actually see the placenta still moving
Yeah.
as if it had a pulse,
Yeah.
even weeks or days later. And grandparents
Wow.
confirm that they saw it as well. So I have had people say it's as if you'd lost a limb, or like as if
Yes.
a woman had left her purse at home when she went out.
Yes.
That they think that could be what the feeling was like. And
Yeah. Some people feel that it's like a twin, it's just another part of you that you lost. So, and then that connection to mom as well, that I think is really important. And I think it's underestimated on the amount of that a newborn has to facilitate in their bodies to move from that intrauterine state to that outside state is such a massive physiological transformation that trying or supporting the infant in feeling the reduction of that stress, it's hard to understand the magnitude of what that means in that child's life going forward. It really
yeah,
is.
you just said a lot. I have so many things to say about. So I wish I could hear that whole sentence back again and take it apart piece by piece.
Well, please.
What is it they do in food? They deconstruct
Yes.
the apple pie, and then you have pieces
Right.
everywhere. Well, as humans, we call it labor. We don't call it picnic. The midwife who taught me used to say that. And I was always taught and have come to experience Earth as a place of duality and work, that where we have to work, we have to do things and maybe learn lessons or do something.
Right.
And I wonder if we are supposed to have blissful births or working births, or some of all the above, depending on who we are.
Right.
My mother always taught me that spiritually we will evolve and we won't have pain.
Right.
And I believe that.
I do too.
I'm not sure we're there yet
Right.
as a whole,
Yeah.
that we don't still need pain to be part of what draws us towards something good and healthy,
Uh-huh.
or you know what I'm saying,
Right.
like
Yeah.
pain as a tool or fear as a
Right.
tool.
Right.
So I don't always know that traveling, when I look at babies coming out, I can't say that every baby coming out is feeling that experience as something difficult.
Right.
But certainly Dr. DeLee, who's this guy who created a bunch of different,
Yeah. A suction device.
yes,
Yeah.
he believed all babies should be born by cesarean because it was a horrible traumatic event to come through the birth canal. And I guess he has some history with his mother that led him to that conclusion.
I see.
And because of him, more and more and more and more moms are experiencing cesarean. That's one reason why that's happening. That concept of we need to protect the baby from stress
Okay.
or pain or difficulty or hardship or having to work hard to make the transition.
Right.
And what's happened is then we have babies through cesarean, and we find they have higher rates of respiratory problems,
Yeah.
more different biome issues,
Yes.
that their moms have significantly higher rates of postpartum depression.
Right.
So it's not necessarily better to
No.
just take away what we perceive as adults as
Right.
adversity.
Right. Or cutting the uterine wall, all of those things.
So much.
Accessing changes in the bladder and the pelvic floor
Mm-hmm.
after birth.
It's a lot to recover from. A regular birth is a lot, and a cesarean birth is a lot.
Yeah.
But when a baby comes through the birth canal, it's like going from a spaceship to outside Earth or space.
Landing on the earth.
You have to go through the lock because they're two completely different environments.
Yes.
Life has to change.
Yeah.
And we didn't set that up, that life has to change.
Right.
This is what life does.
Right.
All life goes
Right.
from one encased environment
Right.
to coming out.
Right.
And yes, humans need the most help, I think, out of all the
Yeah.
mammals, for
Well,
sure.
I think as we look at, colonizing Mars, we all have those viewpoints of being inside that microbiome, right?
Mm-hmm.
And then in order to deal with the atmosphere there, we have to go through these atmospheric locking systems to do that. And that would also be
Mm-hmm. Mm-hmm.
prevalent in ideas of the vaginal canal.
And if we're all born in a test tube, because I saw the Superman movie,
Yeah.
and if we're all grown outside of a uterus and there's no compression, how does that change what we experience,
Yeah.
both physically for growth, as well as if we're experiencing something different, how does that change how we perceive the world?
Right.
Which is really what you were also talking about, the baby's perspective.
Right.
And we were talking earlier about how does the birthing experience set up a baby's perspective? How does it affect how they live their life?
Right.
How do they approach things in their life? And,
Yeah.
as a 30-year-old, what did their birthing experience mean to them, and how they're making decisions and doing things in the world?
Right. It really is a huge impact because of just such the transitions. And I think you're right. So I think us recognizing, okay, you're going to have a different breathing pattern. Okay, you're going to have a different blood and circulatory pattern.
Mm-hmm.
Okay, you're going to actually absorb and bring in and digest nutrients in a completely different way, and then expel it in a completely different way. And
I don't know if I'm ready for that much change yet.
How do we share that with the newborn so that it's not a traumatic first week, right? That we see so commonly.
Right.
I mean, their biggest issues is eating and expelling, and they
Absolutely.
are blown away by filling their diaper, and it is amazing. And I think we don't recognize to say it's okay. It really is. It's going to be okay. We're
That's it,
learning
exactly.
how to do it
Mm-hmm.
differently now,
Mm-hmm.
and we can adapt.
Acknowledging them.
Yes.
I think that's something that it took us a long time in Western medicine,
Yeah.
is to recognize that we need to acknowledge babies,
Right.
that they do feel pain and sensation, and they do draw conclusions that last their
A
whole lives.
lifetime.
And it's taken a lot of scientific study for people to believe that,
Yeah.
because we can't see it. We can't ask them.
Right.
We can't grow up and remember what exactly it was like, generally speaking,
Right.
and say it.
Right.
You know?
Well, we have a history too of really in a society where it's not okay to feel our feelings. And so when we cry or express ill feelings or uncomfortable feelings, what do we do to the baby? We go, shh, it's going to be okay. So we reinforce them and nurture them and support them, but we tell them to be quiet and not to express. But in actuality, say it's pretty rough. Pooping for the first time, all that meconium and getting it out. Or
even more so, it's hard to poop and then realize that you're not pooping because you don't know actually how to relax your anal sphincter.
Right.
Every time you go to tighten a muscle, they all tighten at the same time.
Right.
It takes a lot of practice for a baby.
To
I mean, how many times does it take a baby to see an object and reach out, flailing its arms before it figures out that the object is somewhere that it can get to?
Yeah.
And I mean, pooping's the same thing.
Right.
It's I've learned a lot through actually Ayurvedic and Asian medicine, acupuncture. It's about how to help babies with that. So that we as midwives, the internet, I'll just say, has been an amazing, amazing tool, because we can connect with midwives around the world.
Yes.
And many cultures and places of the world there's so much diversity. We've learned all sorts of new tricks and tools and ways to acknowledge baby and support them and help them move into these new
See, that's
realms of
what's so
existence.
fascinating. That's why I started this website and this online resource is to have practitioners also connect in
Mm-hmm.
their
Mm-hmm.
innovations so that we can grow and share our
Mm-hmm.
expertise and our practices with others around the world. And it really does, it gets access to care to people much, much quicker. And
Mm-hmm.
it's just a wonderful platform for sharing.
Mm-hmm. Mm-hmm.
I love it. And as a midwife, how long do you see your clients for? At what age do you see the mother? And through the postpartum period, how long do you see them? What do you
Um,
experience at that part of the process?
that's a really good question, and I think it varies quite a bit around the world.
Okay.
But here in California, currently, we're licensed for 6 weeks of clinical care for mom and baby.
Wow.
So we do normal, healthy mom and baby care. We can assess that things are normal. When things aren't normal, we refer out to whatever's appropriate.
Right.
Pediatricians, naturopaths,
But you're
chiropractors.
like the first responder. You're like
We are the first responder. We are the
eyes
only
on.
responder.
Yeah.
We are the only responder, our team.
Because a person in the hospital, they get access to a pediatrician that may or may not see everything for 10 minutes in a visit, or they may see their obstetrician too afterwards, but that
Hmm.
again is just a quick look and a quick survey. But you actually come into the home, you
Hmm.
get a home assessment, you see the dynamics, you see them in their natural element.
Hmm.
They didn't have to get up, get dressed, do all these things to go to the doctor.
Hopefully they didn't do that.
And you get to see them more in their natural state. And sometimes that natural state can be in disarray or have difficulties
Hmm.
that may not have been noticed in the doctor's office.
So important. It's so important to be able to address those right away to
Yes.
help support moms and babies. It's so much work in our current culture and our Western style of life. We have so little support, so few people coming in to help, so few sisters and aunts and grandmothers to tell us things to do and ways to help the baby. And yeah, it's very important. I think that's a huge role that a midwife plays. And most midwives in California who are practicing out of hospital delivery will do a home visit, at
Okay.
least one after the birth.
Okay. But
Most of,
has access to up to 6 weeks.
yeah,
Wow.
yeah, yeah,
Wow. What a gift.
yeah.
Because I mean, and not always in the first week do you see problems. Sometimes problems or difficulties arise week 2, week 3, week 4.
Well, of course,
Yeah.
there's so many, and you could devote a whole show just to sort of the spiels that we say.
Yeah.
We typically see people at the first 24 hours, and then 3 or 4 days after the milk has come in, and then 1 or 2 weeks, and then in the office again at 6 weeks. But in my practice, we don't do clinical care, but we offer just holistic conversation, just sharing, all the way through the first year. You
Wow.
know, it's really challenging because postpartum depression is something that's more significant after 6 weeks.
Yeah.
And all of our care, the obstetrician, the midwife, typically their care stops at 6 weeks, but it doesn't stop for the mom and the baby.
Right.
And then they're seeing the pediatrician, but with malpractice, often the pediatrician doesn't do so much with the mom because that's not their scope of practice.
Right.
So then nobody's asking the mom, are you sleeping? Are you this? It's changing. I mean, I see those questions happening in the pediatrician's offices now.
Yeah.
But again, they would not be able to directly give recommendations per
Right.
se to the mom
Right.
so much as they would want to be referring them. And that's what we do. You know, at 3 months, we're definitely looking, is there postpartum depression here? That's a really big question to ask
Yeah.
in our practice at 3 months.
Right. Right.
It's not
Right.
usual, but it's out there, certainly.
Right. Well, and with babies that may have feeding problems and
Mhm.
pooping problems, other kinds of things, sleeping problems.
Hopefully, pooping is a little resolved by 3 months, but
Sometimes.
feeding
Yeah.
changes significantly at 3 months and 6 months.
Yes, it does.
So it's a good time to answer their questions.
Yeah.
Hmm.
And there's a lot out there, and sometimes it's hard to navigate as a new mom on first of all, they may not even know the question to ask. So that's why
Oh,
you as a
rarely
practitioner
know the question to ask.
right.
Yeah.
So it's not like even though they have Google and all of this internet access, they may not know what to access. They may be feeling a certain way or experiencing a certain issue, but then going, do other people have this? Is this normal? Am I supposed to feel this way? All those that sort of thing.
I think that's why it's nice to have a midwife following your care
Yeah.
because midwives offer a little bit longer appointments.
Yeah.
C&Ms in hospitals or birth centers might be a little shorter than the typical home birth appointment,
Okay.
client appointment, but still there's a little more time given, and we for sure on our sheets we all have a place where what else is going on?
Yeah.
How are you feeling? How are you sleeping? How are you pooping and peeing? What did you eat today?
Right.
Did you have company? Did anybody help you?
Right.
More of the how's your whole world coming together, not just the heart rate, the respiration, the temperature,
And the baby weight.
and the baby weight. Yeah.
Yeah.
Yeah. Yeah. So I do agree. It's midwifery is looking at the whole thing as a great big picture
Mm-hmm.
and looking at the family as a whole unit.
Yes.
And what gets the baby in gets the baby out,
Right.
continues the whole baby's life. And so we're really there just as we have been for thousands and thousands of years.
Yeah.
We don't leave the community.
Right.
You think thousands of years ago the midwife was maybe a matriarch or somebody who was clever with herbs or their hands or just your sister
Right.
or another woman in your group.
Right.
And they didn't go somewhere else. They
Right.
didn't go back to their isolated cubicle or their office where you don't have access to them.
Right.
So I think here midwives in our country have developed this since Ina May Gaskin, since kind of this resurgence, this idea of community care,
Yeah.
putting moms together. Some midwives now even do community clinics.
Wow.
So moms will be together getting their prenatal care,
Right.
listening to the baby and measuring the belly and doing their charts and all of that kind of thing. They'll do it together because that group is so missing in our culture
And
nowadays.
creates a collective of,
Mhm.
yeah.
Mhm.
And another level of bonding and another level of resourcing.
Very much another level of resourcing.
Yeah.
Not
Oh.
for everybody. A lot of people in our country really like their privacy.
Yeah.
They're very reserved and they like their privacy.
Yeah.
But particularly postpartum, after you've had a baby, when you're naked having a baby and you don't care anymore,
Yeah, right.
there's sort of a window that's open where you feel a little more, I just want the help I need. It doesn't matter if my clothes are on. Just,
Right.
just give me a glass of water.
Exactly. Exactly. Oh my gosh. Well, thank you so much. And is there anything else that you'd love everyone to know or understand about the work you do?
I really was drawn to this work because I'm interested in the baby's experience.
Okay.
I'm sure that comes from my own experiences as
Yeah.
a human. But for me in midwifery, I really like to support and help the parents to understand their resources and how to communicate, how to make decisions, because I think babies want their parents to work together,
Yeah.
to be their parents.
Yeah.
And sometimes hard, difficult things do happen. Sometimes there's tragedies or just things you weren't expecting, and parents have to make decisions, and they may not agree on those decisions.
Right.
So how do couples talk about that, get information? How do they make decisions? And then how do they support each other if they don't like each other's decisions?
Yeah.
Or if something bad happens anyways,
Right.
how do they stay together and take care of each other? So that's a big place I really look to support
Well, I think
couples.
that's a really important concept to bring up because many people may have it in their minds that, I'd like to be in a hospital or I'd like to be with other, in an intensive care environment to support that if something comes up.
Mhm.
But many times things come up with the baby or with mom that's happening that creates an event that
Mhm.
is unexpected. And that's so neat to talk about because I think in healthcare, we miss some of those elements about creating. Of course, we have family conversations and all of those sort of things,
Mhm.
but we really do miss that close understanding of how to support the family through a decision-making process about
Mhm.
something that they may not have expected. And maybe they thought that if they have that kind of high risk pregnancy or perinatal issues, that then they need to be in the hospital. But I can see from what you're sharing is that maybe they can have, and I'm pretty sure you've done a blended idea of maybe some high risk families that have had situations that maybe wanted to be closer to the intensive care at the time of birth, but then also had a midwife involved in supporting
Sure.
them.
Sure. Because sometimes we have a client who comes in and they're normal and healthy at the beginning of their pregnancy, but later something turns up where it's really important for the mom or baby that they have the access to care in a hospital that we can't possibly give.
Yeah,
It could be surgery, placenta previa,
right.
or
A cardiac defect or
for mom or baby,
yeah,
or diabetes that is not well regulated
right,
with their medicines and that kind of thing.
right,
We just don't have the lab capability, the medicines, the skills to
right,
deal with all of that. That is a hospital thing, and that's why it's such a blessing that we do have medicine.
right. And then
But
you can bring in both, and you can bring in
but
that level of
that's right.
support.
But many clients choose to continue their care with their midwife because
Yeah,
we bring in all the rest of it.
yeah,
We stay with them. I like to tell my clients, it doesn't matter to me how you have your baby. It could come out your nose.
yeah,
You're still going to be a parent.
yeah,
It doesn't matter to me where you have your baby. It
yeah,
could be on the freeway, it could be in the hall of the hospital, or at home in your bed. You're still going to be a parent. What matters to me is how can I be there with or around you that helps you to be what you want, or
yeah.
what's you're led to be, whatever
Right,
your story is going to
right,
be. And we can't know that. So
right.
we're there as, the hired friend, I guess, or
Yeah. Well, and for facilitators for whole health and whole family care.
you say that so well. You should write a book. I like how you pull it all together. Thank you.
Well, I mean, it's challenging
Yes.
because a lot of times in the hospitals, we just hadn't set it up that way. We look at
Yeah.
family-centered care and we look at all those things, but we also look at, being in an area where we're caring for 40 other babies and
Hmm.
other, or 40 delivering moms all at the same time, or all
Hmm.
of those kinds of issues that actually have logistical and spatial issues.
Very much so. Very
and
much.
and access to resources. And so knowing that there are other professionals out there that can help in the before, the
Hmm.
during, and the after,
Hmm.
that Western medicine or hospital medicine hasn't really completely been able to address just because of the sheer volume that they work with. And so having that opportunity to know that you can have one-on-one care
Well,
is really awesome.
I think that we forget that obstetricians and perinatologists were fields of medicine that were created for sick moms and babies.
Yeah,
Family practice doctors used to do deliveries as doctors, and midwives.
right.
And then really midwives were run out of the business, especially immigrant midwives from other countries who had lots of information and experience and help,
Yeah,
both in every setting, right?
right.
And so really what I do is I deal with people who are normal and healthy, or I do something that's more supportive or peripheral when people need to stop in somewhere and get some specific help,
Right,
you know?
right,
So there's no reason why we couldn't be working really together,
right.
medicine and midwifery.
Yeah.
Um, there's no real reason.
Well,
There, of course, are some
I
political,
think our nursing and our
social, and other reasons.
nursing
But
is bridging it to some degree as
yes,
well. Being a nurse, a CRNA, and different.
CNMs
Yeah,
are helping so much.
yeah,
Hmm.
and helping meeting the needs of from a broader perspective and a nutritional perspective, and even from plant medicine, homeopathy, and other herbs that can support in the face of gentleness. I do know lots of physicians that are actually moving to some of those levels because they're dealing with highly sensitive people and they're very sensitive to the pharmaceuticals. They're too strong, they're too
Hmm.
abrupt,
Hmm.
they create
Hmm.
energetic changes too rapidly in the body, and they are going, wow, I need to either titrate that medicine down. And we're doing that a lot more even effectively in the ICUs.
Hmm.
We're not bolusing so much
I mean, giving a
anymore.
big group. I don't
Right.
know if everybody knows what bolus means.
a big
A
amount
big dollop.
of that drug. Instead, we do a little dollop at a time
Hmm.
and titrate that medication and
Hmm.
walk that up
Hmm.
to reach its effect or its desired effect.
But that's because doctors and nurses care.
Yeah.
The systems, like you said, logistically aren't always set up because there's so many being cared for,
Yeah.
which has its own reasons.
Yeah.
But the people within the system
Yeah.
are doing their very best to
Yeah.
work within that system and care.
Right.
And I think that the communities come together,
Right.
and you also see people who care seeing things, well, this isn't working.
Right.
And now that we have the internet and world travel and TV, you can see things in other places working. In
Right.
France, they have some hospitals now where the NICU it's a bed for mom and baby.
Wow.
Where here we have a unit for
Right.
babies and then mom's in her room.
Right.
And what we know, though, through kangaroo care is that babies gain weight and their physiology stabilizes faster
Right.
if they're being touched and held all the time. And
Right.
something they know, especially mom, can be close to them,
Yeah.
that they regulate to that other body.
Right.
And so in France and in some other places, they're working to get moms actually staying in the same room with the baby that's in the NICU, the neonatal intensive care unit.
Oh, I love it.
The opposite of that is when we have healthy moms and babies,
Right.
we now have baby-friendly hospitals,
Right.
which keep baby in the room with mom
Right.
to really preserve that first hour or two. That's so important to the sniffing each other's hormones and settling the systems, regulating the cortisol, so
Right.
that mom and baby both go from a really activated state to a really just
Calm state.
together
Yeah.
state. Mm-hmm,
Yeah.
mm-hmm.
Yeah.
Yep. Yep. Because I mean, they may be feeling adversity, but when
Right.
you get on the freeway, you might feel adversity. And the thing to do is to know to breathe
Right.
and say something nice about the person who just cut you off.
Exactly.
And you'll feel much better sooner
Right.
than later if you do that.
Right. And your hypertension will go down.
Much, much more quickly.
Well, thank you for sharing with all
thank
of
you.
us today.
Thank you. Thank
This
everybody.
was amazing to talk about and to venture down these roads of alternatives and care options that we may not have considered. Thank you so much.
You're
and
very welcome.
everyone have a fantastic day. Thank you.
Thank you. Take care.